Hello everyone, welcome to sqadia.com, and our lecture topic is spinal cord, and we are on the fifth section of the spinal cord, that is the clinical perspectives. In this we will be discussing the lesions of the peripheral nerves. What if the spinal nerve gets transected, whether that's only compression injury only, or whether it's a complete transaction, if it's a partial damage, how does it actually affects, and what are the chances of recovery as compared to the CNS, what are the chances of recovery in peripheral nervous system. Traumatic lesions of the peripheral nerves, they were first described by Seddon in 1944, and actually he defined it in terms of there are three different types of lesions of the peripheral nerves. There is a neuropraxia, there is axomatosis, and neurotomesis. What is neuropraxia? Neuropraxia is the term applied to the transient block. The paralysis is incomplete, recovery is rapid and complete, and there is no microscopic evidence of nerve degeneration. For example, this is classically in case of if we blocking in form of giving any regional or local anesthesia. This is what we achieve, that is called as neuropraxia, that we have blocked the sensations, we have blocked the nerve in terms of that it cannot conduct impulses, but there is no anatomically or morphological damage to the nerve. Axomatosis is a term applied to the nerve lesion in which the axons are damaged, but the surrounding connective tissue sheets remain more or less intact. Functional recovery is more rapid and more complete. It's kind of a partial injury. That yes, axons are damaged, but outside there are three layers of perimysium, endomysium, and myomysium. These are actually not damaged. As a result, the nerve fibers, when regenerate, they come more aligned to each other, and as a result, almost complete recovery occurs most of the time. But in neurotomesis, it's not just the axon which is damaged, the coverings are also damaged. So actually it is the complete transaction of the nerve, a peripheral nerve. Neurotomesis is the term applied to the complete section of the nerve trunk. The muscles that are innervated show flaccid paralysis and rapidly waste. The reflexes in which the muscles participates are lost. So there is areflexia and there is flaccid paralysis. There is a total loss of cutaneous sensibility of the area exclusively supplied by the nerve. For example, if for any reason C5 would be damaged, or our fibers which were arising from the C5 have actually damaged over here in the axillary nerve. So what will be the loss? The regimental batch area of the right shoulder there would be no sensation present here. The axillary muscle, actually this deltoid, would waste, and this would result in the shrugging the shoulder would be compromised because that's the function of the deltoid. Section of the peripheral nerve results in the imputation of the postganglion sympathetic fiber as well, traveling in the nerve. As we just studied that a spinal cord, there is an anterior root and there is a posterior root. Through the posterior root, then there are sympathetic and parasympathetic chains which are actually paraspinal in nature. That is, they are descending as along side by side toward the vertebral column. Now they are giving off fibers which pass through the posterior spinal root and then into the spinal cord. If the roots are damaged, then this also results in the damage of the parasympathetic sympathetic fibers as well. So they will also be sectioned and they will have effect on the vascular as well as other areas, for example cutaneous sensation, vascularity, similarly loss of sweating and sweat glands. They are all under control of parasympathetic sympathetic fibers, so they will be affected as well. And as a result of a vascular control, the skin area at first becomes reddened out because vasodilatation cannot be controlled. Veins or arteries would dilate automatically. Similarly, if they're exposed to cold, they cannot be vasoconstricted because the fibers are lost. Later, the affected area becomes blue and colder than normal, especially in the cold weather. If the large area of the body is denervated, as in case with the sciatic nerve is sectioned, the bones undergo decalcification as a result of the disuse and loss of circulatory control. Now, sciatic nerve is one of the major nerves of the lumbosacral plexus. It descends down from the hip and pelvis, then into the posterior thigh, eventually bifurcating into tibial and peroneal, and then superficial and deep peroneal, and almost supplying all the musculature of the leg actually. If that is lost, not only it results in a foot drop, actually all the muscles are lost, the reflexes that are lost. For example, the ankle reflex would be lost. Similarly, this would result not only the loss of facial paralysis as the reflexes, but even the bones actually, which are been some fibers of these nerves are actually supplying the bones as well, because according to the Hilton's law, it will supply the muscles and the area the joint it crosses, so that it has to supply those bones. Eventually there is decalcification and bones actually become highly osteoporotic. So how does recovery actually occurs? Regenerating motor axons grow at an average rate of about 1.5 millimeter per day. The proximal muscle will recover first and the distal muscle will recover later. Sensory recovery occurs before there is a return of voluntary movement. The part of this nerve distal to the section becomes very sensitive to the mechanical stimulation once the regenerating sensory axons have entered the distal segment. This sign is referred to Tinel sign. In this Tinel sign is actually elucidated if on any area of the distal, if there is a transaction at any level, and you know the path of the distal segment as well. If you percuss it quickly over the distal segment of the transected nerve, this would result in a tingling sensation. Why? That actually means that the nerve is in process of recovery. The fibers from the proximal portion have actually sprouted and reached to the distal segment, and then the process of merging together to form a complete recovery may be possible at this time. Now this is what I was talking about, and we know that the peripheral nervous system, there are two major plexuses in the body, the brachial plexus and the lumbosacral plexus. So if it starts from C5, C6, C7, C8 and T1, and if that is not there, what is the damage? If it happens at C5, there's a cutaneous sensation of the regimental batch area, the function of deltoid is lost, mainly over this. C6 is that the bicep is mainly lost, which is the major muscle, and it has a role in flexion of the elbow. When the C7 is lost, similarly the triceps and the flexor carpi radialis is lost, and tricep function results in the extension at the elbow is not possible. Similarly, T8 is actually mainly supplying the flexor digitorum superficialis and profundus muscle, which means the flexion at the wrist joint would be lost. Similarly, flexion of the finger and is actually lost as the C8 and T1. Coming to the lumbosacral, at L1, the dermatome is the groin dermatome, but major muscle is iliopsoas. If that is lost, the flexion at hip would be compromised. Similarly, L2, L3, L4 are the roots values of the femoral anterior part of the thigh would mean the femoral nerve would be damaged. That would mean the extension at the knee would be severely compromised, as the femoral nerve mainly supplies the quads of the thigh. So L4, L5 and the posterior root gives rise to sciatic nerve. If sciatic nerve is damaged, that would result not only in the foot drop, but similarly loss of hamstring, flat paralysis. Similarly, all the musculature from that part onward would be lost. Sacral region, the dermatome is the lateral edge of the foot. Similarly, and S2 is the posterior part of the thigh. The muscles which are lost in S1 are the gastrocnemius and soleus, which actually means that ankle reflex would be lost. Although there is no reflex with S2, but there is cutaneous sensation is around the anal region. S3, S4 is around the anal region, so that can be lost if the more sacral segment, lower sacral segments are damaged. In this section, we have covered what are the different lesions of the peripheral nervous system. We have covered what is neuropraxia, what is the partial loss like exonotasis, what is the complete transaction like neurometasis, and how the recovery from that is possible. We've also covered that if the nerve is damaged, what the dermatomes are damaged, or the muscle, what muscle fibers are affected, what are the reflexes which are lost actually when a certain nerve which transacts at a different level. For more content like this, keep watching sqadia.com. Thank you very much.